Hello, everybody. We are here again in São Paulo, Brazil, at Dante Pazanese. It's a great pleasure to be with you again. Without any wasting any time, we go direct to the slides. Dimitri, please.
Thank you, Fausto. So, hi everyone. We have a very challenging case for you today. This is a 60-year-old lady who presented to our hospital recently with symptoms of heart failure, now in class 3. She has a lot of previous cardiovascular procedures. She underwent a surgical mitral valve replacement in 1993 and in 2006. And she had a BioCore 29 millimeter bioprosthesis implanted. So she has also atrial fibrillation, diabetes, hypertension, and hypothyroidism. Her lab tests are unremarkable except for a low hematocrit and a mild reduced renal function. 49 is the GA4.
Hmm.
You can see on the chest X-ray, cardiac enlargement, and signs of pulmonary congestion also. These are the echo findings. She has a severe mitral bariprosthetics dysfunction. I would say mixed etiology, both
Uh-huh.
regurgitation and stenosis.
Hmm.
Here we have the transmittal gradients, 36 and 13 millimeters per mercury.
Hmm.
We're going to see some live images in a minute.
Hmm.
The leaflets are thickened and calcified, as you can see here, with severe restricted motion. The ejection fraction is well preserved, 6.6, and she has also moderate tricuspid regurgitation, and systolic pulmonary pressure was estimated to be above 80.
80. Wow. Hmm.
So in summary, Fausto, a
Mm.
female, 60-year-old, severe mitral bioprosthesis dysfunction, tricuspid regurgitation, pulmonary hypertension, third surgical mitral valve replacement now if this patient is considered to perform another surgery. I think that the ARI score and the STS score, they don't reflect the actual risk
Yeah.
of this patient
Because
for
we are
another
facing
surgery.
this kind of patients here in surgery, and the mortality rate is much higher than we can expect
For
from
sure.
the even the STS or EURI score.
Yeah, for sure.
Yeah. So we have a lady with two previous open heart surgery with severe pulmonary hypertension. Maybe you can look at the echo
The echo, okay?
image.
And here we have the transthoracic echo, the parasternal long axis view, where you can see the bioprosthetic mitral valve with the huge calcification of the leaflets. At the short axis, we can see that there is a nice left ventricular systolic function, while we can see right ventricular dilation with some degree of systolic dysfunction.
Hmm.
At the apical four-chamber view, we can see the color flow mapping from the bioprosthetic mitral valve, the enlargement of left and right atrium. The gradients were the peak one, 23 millimeters of mercury, and the medium gradient around 6. So at the right side, severe central regurgitation
Hmm.
across the bioprosthesis.
Hmm.
This is the 3D image,
Hmm.
this unfaced view. So we have the right atrium, the left atrium over here, and the left atrium and the left ventricle across the valve. We can see that there is no mobility of one of the leaflets. The effective area was estimated in zero point 0.6 at that time, but we have to keep in mind that this patient is
Hmm.
under anesthesia, so
Perfect.
you can have some differences
Okay.
between
Hmm.
the previous and this.
So what is the main discussion in the heart team?
Well, Fausto, in fact, this patient was randomized um, to our trial, Survive
So
trial.
we learned from the past, when you have doubt, you are in doubt, you should
Yeah,
randomize.
yeah. Yeah, and this patient was selected for our trial. This is an ongoing trial, a randomized one. We have some challenges during selection of this patient from the anatomical perspective for transeptal mitral valve involved. I mean,
I mean, I'm
patients
talking
with
about the
a
surgeon. The
with
surgeon
with
first.
a low LVOT obstruction. But for surgery,
Uh-huh.
I think that pulmonary hypertension
Is the main
and
exclusion.
tricuspid
And over 100?
regurgitation, yeah,
Over 100.
patient with
I
almost
mean, I think
suprasystemic.
in US or even in Europe, they don't have those kind of patients with severe pulmonary hypertension
Yeah,
in these patients. That's
and
what.
and younger patients.
Okay, great.
Okay, this is a challenge for you guys from the transeptal function
Uh-huh.
because you can see some calcifications. Okay, can you see spread in all the septum over here? So it can make a challenge for
Yeah,
you.
Okay, great. So we
we
have a very hard, if I can say that, septal,
yeah.
the atrial septal,
Hmm.
and we also have severe pulmonary hypertension. So the patient was randomized.
The patient was randomized to mitral valve involved.
Uh-huh.
We did the CT before randomization,
Uh-huh.
obviously, and as you can see here, the CT findings, the true internal diameter is 25,
Uh-huh.
and we are planning to implant a 29
Wow, it's a
Sapien
huge one.
3 with
Big one.
over filled
Mm-hmm.
Sapien 3 THV.
Mm-hmm.
Um, we estimated the risk of LVOT obstruction, and the new LVOT area is above 200 millimeters square.
What is the exclusion of the neo LVOT?
For the trial, 150
150.
square
Okay.
millimeters.
Okay. I mean, in other words, you can provoke, you can cause an LV obstruction
Yeah,
if it's lower than
yeah.
150. Okay.
This is the suggested projection that we are
Hmm.
going to use for Sapien 3
Hmm.
implantation. And like George just said, we can appreciate here two anatomic features that can difficult the procedure. First one
Hmm.
is the calcified interatrial septum, as you can see here.
Hmm.
This patient, she doesn't
But the
have,
calcium is not in the whole septal, yeah?
yeah, but it's in the interatrial
Septal,
septum.
okay.
And this patient, she doesn't have a huge left atrium
Hmm.
like we used
Yeah.
to see in the trial, for example. We perform ultrasound guided puncture of the femoral vein. We got radial access for hemodynamics,
Okay. And can you show the radio, please?
and we already performed the transeptal puncture, Fausto.
Oh, yeah. So just reviewing for those just came to watch right now, we already did the punction. Dimitri did the punction, the atrial septal punction that was very calcified. He had a hard time to cross the septal with a regular guide wire. He needed to use a 14 guide wire, like we use in the coronary percutaneous intervention. And he used a 14. He predilate the septum with a 3.5 balloon just to open a little bit and to across. After he did that, he exchanged the introducer, I mean the catheter, by the Agilis, and he tried to come with the regular 35 guide wire. He could not cross. He needed to use a hydrophilic guide wire, but he used to get a better support. Instead of a pigtail, he used a multi-purpose catheter, MP, and after he placed over there, he put the pigtail and he brought another wire, and now he's bringing the confident guide wire with a specifically curve, and now he's gonna procedure
With
a
septostomy.
the dilatation of the septum with the balloon, atrioseptostomy. So, what is the size of this balloon, Alberto?
This is a balloon of 14 to 40.
So 14 by 40.
Yeah.
He's placing the balloon there. Now
Não vejo.
this procedure is guided by echo. You can see the image in the echo, the balloon in the septum. That's going to be inflating now.
Right.
Can you move a little? Okay. Can you see the constriction? It is a very calcified. Open the septum quite well. And you can see that by echo. George is going to tell us if the opening is enough to cross with the valve.
Okay.
Do you think the anatomic curve is okay, Dimitri? Just to see where we are going to put the curve up there.
Yeah, we punctured the septum about 2.2 centimeters from
Do you
the
think this
mitral
is the
valve.
ideal position?
Is the position that we thought that was safe, Fausto, because
I
it's
know.
the only point that it was not so calcified.
I remember the first mitral valve case that we did here in the 360. We need to do 3 punctions. Hopefully,
Yeah.
we don't need to repeat that 3 times.
Usually we predilate the septum twice,
Mm-hmm.
and now we can check with the balloon the trajectory of the system, just to simulate the movement that the sapien 3 is gonna have. Okay,
So,
I'm gonna cross again.
and Alberto, what is the role of transits of echo in a procedure like that? Do you think it's so important to have it to guide the punction and everything?
Yes, Dr. Fausto, it's essential for the septum puncture. We have to reach the perfect region to have March to curve the valve and cross the septum and cross the bioprosthesis prosthesis. And sometimes we have some prostheses with no radial pack markers. So the echo is really important to help us to position the THV.
So how about the heparin at this time? Well, what is the regimen of anticoagulation before the puncture and after the puncture? This patient probably was under anticoagulation, oral.
Usually we use 2,000 units.
So you stopped the oral
Yeah,
anticoagulation,
we stopped the oral anticoagulation.
kept under enoxaparin.
Yeah.
How about if you need to do another septal punction? Do you?
So that's a very important question, Fausto. In this case, we're gonna leave guide wire, a safety guide wire in the left atrium, just to predilate again if needed, if you have some difficulty in crossing with the sapien 3.
That was very good. Very good to know.
So
that.
we are with in the left atrium again with the Agilis, and we're gonna place another wire here, a body wire.
So here we can see the transesophageal imaging at 37 degrees. At the left side, we have the right atrium, and right side, the left atrium. We can see the balloon completely expanded over here. And we can see over here again, and over here again, while the balloon was dilated. So we can see here the left atrium and right atrium. And the result was really very good.
So the hose is enough
think it's
to cross
large
with the valve. You guarantee.
Yes, I guarantee.
So we can see here the skirt proximal to allow antegrade flow. And we need also that the Edwards logo should be face down,
Like that.
Okay.
just to get the right orientation during a deflection through the septum.
That's perfect.
And like we said, we're going to use a 29 overfilled with 3 cc more sapien 3.
A coordination with Alberto is holding here. If you can open a little bit the camera, you can see Alberto holds, Alberto hands holding the device and also the guide wire. Dimitri is advancing, and Alberto is holding the guide wire. So, watching the angel and pushing the valve. So, see, this is Alberto hands right here.
And also, we don't need to introduce the sheath all the way to the body, because the distance from the femoral vein to the left atrium is shorter than the femoral artery to the aorta.
That's another tip. So if you
to-
look at the sheath introducer in the femoral artery, if you bring the camera a little bit here, yes, right here,
And then we are ready
you see
to,
the sheath is not completely introduced
yeah.
because
And
the
then-
distance into the left atrium is short.
And now we are ready to retract the balloon inside
Now
the
Dimitri
sapien
is
tree.
retracting the balloon, as you can see that in the floor, and Alberto is doing
Yeah,
unclockwise.
and clockwise to do the fine adjustment
Yeah.
for the balloon inside of the THV.
So the balloon is almost there in the mid portion of
just-
the valve, or the stent
I
valve.
think it's
Is
a
that
good
co-
position.
Okay.
You think it's okay, Dimitri?
Yeah.
Yeah,
And then the projection that we selected,
Yeah.
Let me see here.
22
22, right?
with 3 cranial.
So we are just looking at the view, specific
22.
view, 22 by 3. Now Dimitri is going to test the pacemaker.
So pacemaker on.
Pacemaker is
100?
only the wire.
Yeah.
Which wire you're using?
This is the confident wire.
Okay, but the pacemaker is in the confident wire?
Yeah, yeah.
Okay.
Okay. We are good here. Hold the wire.
Yeah, I'm pulling a little bit.
Hold the wire.
With the
Almost
wire,
there.
good. That's very important
Okay.
point.
Yeah.
Okay. So I'm gonna retract the pusher here.
Now to the monitor that you were watching, yes, you can see some signs of the old valve over there. And maybe do you use the echo to see the?
Yes, we
position?
can use the X to check the
Do you
position.
think the position is good,
Yes.
George?
If you can see,
Do you think it's too atrial?
yes, not as usual.
Yeah.
Maybe you can go forward to the left atrium just a little bit more.
Okay, great.
Okay, we're gonna do a very slow inflation here. Vai, Alberto. Vai. Puxando, tá? Vai.
Ok.
Vai. Go, 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 go. Vou puxar um pouquinho. Go, go. Vai. Vou puxar mais um
Ok.
pouco. Vai. Go, 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 go. Vai. Vai.
That's an important
final.
1,
Dois.
time of the
3.
procedure.
4, 5.
Okay. So it's about
Pacemaker off. Okay.
It's good. Can you
speaker
connect
is
it?
off. The blood pressure is recovering. Great. Now pulling back the balloon. It was a great demonstration.
We can see that the peak gradient is around 6. Do you remember it was around 22? And the mean gradient less than 2. It was 6. No, there is no valvular leak.
how was the
And the
gradient
opening
before
of
the
the
procedure?
leaflets is very good.
13.
And there is a mild
36
central
per
regurgitation,
13.
I believe, because you have some guide.
Yeah,
some guide
because of the
inside
wire,
the
right?
process, yeah.
But we don't have here in our country a large non-compliant balloon to perform
Post dilatation.
post-dilatation.
Larger than 29.
28, for example, or 30.
We don't have it.
This is I think it's a requirement.
How often do you post dilate valve-in-valve procedures in mitral?
Maybe 30 to
32%.
40%
You're a little
of
bit more
cases.
conservative
Yeah.
with this.
It seems to be just a mild tricuspid regurg.
Just mild. It was at least moderated.
It was moderate, yes.
So what are you going to do now?
We're gonna measure again the left atrium pressure,
Great.
and we are ready to
Great.
end the case.
And how do you make a decision if you're going to close the atrial septum or not to close, to keep it open during
Well,
the
let's say
evolution?
less than 5 to 8% of cases we need to
You need to
close.
close.
Yeah.
So you're going to follow
Generally,
this patient.
if the
How do you
patient
follow
has
this patient? By echo, by
hypoxemia or
Oxygen. Okay.
some instability during the procedure. So also this patient is going to be, we're going to take care of the access. Patient is going to be extubated in
Are you
the
going to use
room.
a
Yeah,
ProGlide?
a ProGlide, just one ProGlide. She will be extubated in the room. She's going to be at our cath lab for 4
Recover
hours
right here
to
in the cath
recover.
lab.
Yeah. and then she's gonna go to the ward, and probably tomorrow
Go
he
home.
will be discharged home.
Oh, that's in the okay, great. Now they are working on that. I'm gonna take this here. I don't like to see blood. Okay. How long are you gonna keep this patient anticoagulated? For how long time?
For at least 1 year.
1 year.
Yeah, and I'm gonna check echo and CT, like I said before.
Warfarin.
Yeah, by protocol.
My protocol is warfarin
Yeah.
1 year.
Yeah.
How about the patients that goes to surgery? It's only also 1 year.
They get anticoagulation for 3 months, and they are gonna perform also CT and TE at 3 months and 12 months just to compare.
As a randomized
Hemodynamics finding.
study, don't you think you should keep those patients, the surgical patients, also for 1 year of warfarin?
Fausto, in fact, we left to the clinician. Thank you, Fausto.
To you guys.
Thank
So
you.
I'll meet you just in 1 minute in the next lab 4. Thank you. See you.
Bye-bye.